Hello, hello. So my name is Heather Clark, and I am the ambassador for the Usher Syndrome Coalition. My type is 1D, and I would like to introduce Dr. Levin. He is the chief of pediatric of Albany, and sorry, I'm just gonna make this a little bit easier. Chief of pediatric ophthalmology and ocular genetics, and the chief of clinical genetics. Go ahead. At the University of Rochester Medical Center. He's over 35 years of experience working with patients with Usher syndrome and other inherited retinal disorders. His focus has been on developing low-cost, open access, non-for-profit, therapeutic options for patients. And he'll be discussing the real world of treatment option development for patients today. Thank you.
Thank you very much. For those of you who'd like to know, I am an ugly guy, 5'11", big ears, big nose, and a distinct lack of hair. You can recognize me as probably the only person here with a suit and tie. But it's great to be here, and thank you very much for bringing your conference to Rochester. We're delighted to have you. Our team is here. Our genetic counselors are out in the lobby. You can ask questions of them at any time, not in the lobby, in the foyer there. And it's great to have you here. So welcome to Rochester. Enjoy it while you're here. I'd like to begin by saying, and I can say this quite confidently, that I think that every single patient in this room, regardless of your age or your status, will have some type of treatment for your RP within your lifetime. I think that's a fact. I don't think I think it's no longer an if, it's just a matter of when. It's not going to be today. It's not going to be by Monday. It won't be by August 1st, and it won't be by the end of this year. But treatment is coming, and I want to tell you a little bit about what treatment will look like and what we're working on and others are working on. My disclosures, we work with several companies doing gene therapy and other types of treatment for a variety of diseases, in particular X-linked RP, the RPGR gene. We have a trial going on right now with a gene that has neurologic degeneration and retinal degeneration, called CLN5, a form of Batten's disease. But my focus and our focus, and we work with the University of Iowa very carefully, is to create low-cost, open access, no drug companies involved, treatments that anybody can get their hands on. And we're going to talk a little bit more about that later. So who wants to be in a clinical trial? Raise your hand. Like every hand goes up, right? Everybody wants to be in a clinical trial. Everybody wants treatment. And the question is, what options are there? And what's required to be eligible? Because not everybody can get in every trial. And there's general categories of treatment. One is the gene therapies, which are gene-related. They could be replacement of the gene, where we give you a new gene to replace your bad gene. They could be fixing of the gene. You've heard about using CRISPR or other methods to bypass or fix a defect in the gene while it's still in your eye. Those are gene-based therapies. Stem cell involves taking either your cells or another person's cells, putting them into your eye with or without a gene-specific fix to either restore or preserve vision. So for example, we have available to us now the ability to take a tiny little biopsy of your skin, 3 millimeters. It takes 2 seconds in the office. We can take those skin cells into our laboratory. We can grow those skin cells. We can turn them into retinal cells. We can fix the gene defect. And then using this machine, which is a robot, pick them one cell, one rod or cone at a time, put them into a little grid that we print on a 3D grid, slip it underneath the retina, in the middle of your retina, and let those cells grow and attach to other cells because the rest of the retina is still working in RP. This is a very real thing. It's being done in animals. It's showing good promise in animals. And if you have, this is an OCT, cells that are alive still, these cells can connect. That would be a form of stem cell, and since it's your cells, you can't reject your cells as opposed to getting someone else's cells. The other form of treatments are gene agnostic treatments, where it doesn't matter what gene you have, like you just heard about J-site, where either factors or cells carrying factors or gene therapy is put in to help preserve or restore vision using those factors like rod-derived cone viability factor, or using optogenetics, where you would inject pigments derived from animals into your retina to take cells which don't normally see and turn them into light-sensing cells, and that's being done right now as well. Another idea is to use drugs like NAC, N-acetylcysteine, using antabuse, which is a drug that alcoholics take to prevent them from drinking. If you take antabuse and you drink, you get very, very sick. That's how you prevent the alcoholic from drinking. Well, it turns out that that drug also works in the retina to unscramble the messages of vision that happens when your photoreceptors die. And that can improve your vision, at least in mice. And we're going to be starting a study very soon on that, regardless of your gene, for patients with RP and other retinal degenerations. We're going to start with alcoholics first, who need the drug anyway, and then we're hopefully going to open that up to people who are not alcoholics. So these are all gene agnostic trials. Doesn't matter what your gene is, where we can go and try and help slow down your RP or perhaps improve your vision. So what's required to be eligible for all these things? Well, the first is you need a diagnosis, right? And getting a diagnosis isn't so easy. Just saying you have RP sounds easy, right? Everybody looks in, you got RP. Well, we did a study of patients who had Stargardt's, who came to me with Stargardt as their diagnosis. 39% of them had the wrong diagnosis. The misdiagnosis for RP is even higher. It's the most common wrong diagnosis I see in my clinic for a whole bunch of reasons. Because these are rare diseases, and the doctors in the community can't recognize rare diseases. They don't see them all the time. And then they come and they say, oh, I know that word, it must be RP. And it turns out that it's not. After you get a phenotype or a clinical diagnosis, you need to get a genotype, a DNA diagnosis. That gets you into a gene-specific trial because you need to know your gene. Again, that's not that easy. Getting a diagnosis means getting a detailed ocular and whole body examination and history, because other parts of your body, as you all know, hearing as an example, may be affected with RP. We take a look at your whole family tree. That's why our genetic counselors are here. I couldn't practice without our genetic counselors. We do a complete eye exam and sometimes a whole body exam. Then the diagnostic testing, audiology to look at your hearing loss, vestibular testing sometimes, and all the tests you get when you see the eye doctor, your OCT and your ERGs and blah, 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 blah. All of this is required to get you a diagnosis. And there are many causes, as you heard earlier, of hearing loss and poor vision. In fact, in the undeveloped world, Usher is not the most common cause of hearing loss and blindness. It's congenital rubella syndrome. So getting a diagnosis gets you to a genetic test, and then we have to ask the question, is your gene diagnosis correct? Nowadays, it's so easy to get a gene test. We find patients, they come to us with their papers, and we look at those papers, and sometimes it's wrong. There's something called the false genotype rate, because when we order big tests with lots and lots and lots of genes on the panel, everybody in this room, whether you have Usher or not, is going to have abnormalities. And we have to decide, are those abnormalities causing your disease? And that's a process that involves other family members and a lot of research to try and figure that out. And we don't trust the lab report. We check every single lab report that comes in to make sure it's accurate, and we believe the results that the lab interpreted. Many times we have a lab who says one thing, and we turn out that it's actually wrong. And it has to match what's wrong with you. We have to have the right gene. Now, I'm not saying that all of you should start worrying, do I have the right gene that the doctor told me? No, you're probably all under the care of very good doctors who know what they're doing and have done this process already. But it's important to know what your genotype and your phenotype is before entering a clinical trial. And sometimes there's this urge, you want to get into trial, so you force it, right? Like, yeah, I'm going to make this gene, yeah, this is my gene, so I can get in a gene trial. Or yeah, I got Stargardt, or yeah, I got RP. And you're squeezing just to get into the trial. And you have to be cautious of that. We understand how much you want to get in. But if you get in with the wrong diagnosis or for the wrong reason, obviously it's not going to work. It's like putting a cast on your arm for a broken leg. Once you have a clear phenotype and a clear genotype, that is a clear clinical diagnosis and a clear gene diagnosis, then you can search for options. There's a website, clinicaltrials.gov, that lists all the trials that are active, hundreds and hundreds and hundreds and hundreds of trials. You can type in Usher, and it'll give you all the trials. But be careful. Just because it's on that list doesn't mean it's good and doesn't mean it's for you. There are some very bad trials on that list, trials that I would not enroll my dog in. I mean, there are some dangerous trials on that list. So how do you figure that out? Well, for us, we do the research to figure it out. Someone says, what about J-site? What about NAC attack? We'll do the research and give an honest opinion to the family, to the patient, whether we think it's for them. We know everybody in the ocular genetics community. There's only about 60 or 80 of us in the world. We know each other. We know what's going on. And we can get the inside scoop on these studies. You have to check the inclusion-exclusion criteria. Like you just heard, if your vision isn't 20/80, if your vision is better than 20/80, you can't get into the trial. Well, there have been many situations where patients have kind of fudged their vision to get in. Make it a little better, try a little harder, squint a little harder, turn the lights down to get into a trial. That's forcing it, right? Inclusion requires age, you gotta be the right age. You can lie about your age, vision, the symmetry of the disease between the two eyes, what language is the consent form in? If your primary language is in English, can you get into the trial? That's a problem in some populations. And location, as you just heard, they're going to pay for you for J-site. A lot of trials don't pay. Maybe you don't want to travel to California 4 times a year. I can't see why, but there are reasons. There is cost and inconvenience associated. You got jobs. Can you leave your job to do this? And then there are data points that need before some trials. You have to get an OCT. How many times? Are you getting the right kind of OCT? There's a test, maybe it's called the Maya test, which is a kind of visual field. Does your place have the Maya test? So you can get into these studies. And of course, for gene therapy, you need to have live cells in your retina that can take up the gene. If all of your cells have died, then giving gene therapy won't work. You would need a stem cell treatment. So you have to have the right treatment for your disease and therefore the right evaluation to know whether you can be included in a trial. And you have to know if the site is accepting patients from everywhere. And are there open slots? Do you have to travel? How far do you have to travel? Can you come from another country? All these questions have to be answered. And lastly, do we know them? Do we know these people? Are they good people to do a trial? Do we trust them? Are they in it for the money? Are they bad people? We know all this, and we can figure that out to help them out. You also have to consider what your expectations are in a trial. Again, the cost and the commitment. It is a commitment, and there is a cost. And you have to realize it is research. It is not a treatment. Clinical trials are research. We don't know what the endpoint's going to be. It's incremental research where we learn step by step about safety and efficacy, and we know more and more as each step comes along, and it takes time, but it is research. And until it's approved as a treatment, like Luxturna was, for a specific form of RP due to a specific gene called RPE65, it's still research. We're always wondering, is it going to stop the progression of the disease, or is it going to restore vision? There is no treatment that's going to restore everything about RP, where your night vision is going to come back, your peripheral vision is going to come back, you're going to be seeing 20/20. There's nothing on the horizon even that could completely do that. But keeping central vision would be really terrific. And there's possible adverse outcomes. Luxturna, the treatment for RP65, looked great. Didn't work in everybody, but for those where it worked best in low illumination. But now, down the line, years later, we're finding out that some of them are developing atrophy in the retina, retinal scars, and perhaps getting worse. There's long-term effect. Remember, drug companies are trying to get these studies through quickly to get results quickly in a disease that takes years and years and years to progress. So there are going to be some unknowns. So you could get worse in a clinical trial, and you have to consider that as well. Basic principles that we're recommending to our patients today. Number one, avoid systemic harm. Is it really worth it to have to take immunosuppressants, that is to suppress your immune system and be at risk for infection that could be very serious, for a clinical trial to research whether it's going to be good for your eyes? Number two, avoid retinal injury. We're not really recommending optogenetics because if you get an injection of optogenetics, and also if you get an injective experimental stem cell, one, could it injure the retina? And two, would it make you ineligible for a gene-specific trial that is coming down the line not too far from now? Would you have essentially blown the opportunity to get into a more gene-specific trial? And lastly, avoid disqualification from future trials. And there are many things that do that, but the gene-agnostic medical trials like NAC and Antabuse and things like that and others, metformin, that's not going to affect your ability to get into a future trial, most likely. It's the ones where we're injecting in the eye where that's an issue. Remember, you're desperate. I get that. I see patients every day. We hear it. We see it. We understand. You want a treatment. You want it yesterday. But the disease is slow moving. And as much as it's frustrating to hear the slow pace of research, you have to realize that actually research is really fast moving. There are multiple clinical trials out there, tons of clinical trials for retinitis pigmentosa various forms. The future is really bright. As I said, there will be treatment for all of you. Sometimes, though, the best thing is to do nothing. Just hold on, wait. You don't need a treatment tomorrow. You don't need a clinical trial tomorrow. Think about it, evaluate it, work with your doctor to see if it's right for you, whether you're eligible. Many patients say, well, wait a second. Even when treatment comes, how am I going to afford it? It's going to be a fortune. Luxturna just raised their price. It's now close to $1 million per patient. Spinal muscular atrophy is $2.2 million. Hemophilia is $4.4 million. The prices are just going up. And how are you going to afford that, right? Now, supposedly, every patient who's gotten Luxturna, and just about everybody in the country who's eligible has been treated, there's only 17 treatment sites, we're one of them, has gotten insurance approval. But that's not going to work for every single gene. It's just not, the system can't bear that, paying millions and millions and millions of dollars. The net worth of a human being in the United States, if they take off all their clothes, sell their clothes, their books, their house, their home, everything they own, and walk naked into the desert, is $82,000. It's not going to work for $1 million treatment. We have to come up with something better. And that's why we're really focused on not-for-profit, low cost, open access, no patent. Anybody can call us up and get the drug. And that's what we've been working on. Our first gene is going into trials, we hope, within the next 12 months for another form of retinitis pigmentosa with another gene, not an Usher gene. And we do that with philanthropy. And over $140 million has been raised in the last 10 years to drive this process at the University of Iowa. The surgery will be done at Rochester. So that's another method of making this affordable to people, because we have a problem with the cost of drugs in the for-profit model. Lastly, basic principle, do no harm. That's a basic foundation of medicine. Primum non nocere, do no harm. Desperation leads to bad decisions, but clinical trials need you. If you want to help the research agenda, you have to enroll in clinical trials to help get the patients to get the trials done. But you have to ask these questions. Is the trial for you? Don't force yourself in. Think about these questions that I've raised and work with your physician to make the right decision. We live in very, very positive times. You will be treated, especially if you're younger. In fact, I would go so far to say that when I see a baby who's had a hearing test, hearing genetic panel, and it comes back with USH2A, and I see a 6-month-old kid, I tell them, you're never even going to experience RP, because you'll be treated. Treatments will be here before you ever have a symptom, most likely. That's the world we live in today. And we're going to get there. There's no question. Just a question of when. Thank you very much.